بسم الله الرحمن الرحيم. دكتور أحمد طاهر، مدرس طب الحالات الحرجة، كلية طب جامعة القاهرة، وكونسلتنت كاردياك الكتروفيسيولوجي اند ابليشن. محاضرة النهاردة عن Supraventricular Tachycardia Diagnosis and Management for Intensivists. Definition of supraventricular tachycardia is tachycardia with a heart rate above 100 beats per minute that arises from above the ventricle, either from the atria, AV node, or his Purkinje system, hence the name supraventricular. Usually it presents itself as narrow complex tachycardia with QRS duration less than 120 milliseconds, but sometimes can present as wide complex tachycardia in cases like pre-existent bundle or independent bundle branch block, or something like AV antidromic AVNRT or pre-excited tachycardia. The diagnosis and management of various types of wide complex tachycardia and how to differentiate VT from other causes of wide complex tachycardia is covered independently in another lecture. So we won't focus on this in this lecture. Brief talk about mechanism of tachycardia. As we know, there are three mechanisms. One is enhanced automaticity, which is abnormal phase 4 depolarization in tissues with pacemaker activity. Rapid firing or rapid depolarization in this phase causes enhanced automaticity or abnormal automaticity. The second mechanism is trial activity due to early or delayed after depolarization occurring in phase 3 or phase 4 of action potential, leading to triggered activity. And finally, re-entry, which is almost the most important mechanism. In this case, for re-entry to happen, we have to have two limbs of re-entrant circuit. One of these limbs conducts in one direction fast, and the other limb conducts in the opposite direction slowly. And this formation of wavefront activation causes re-entry around an area of electrical silence. We're going to see this in many cases of supraventricular tachycardia. So, what is the differential diagnosis of narrow complex tachycardia? We can categorize narrow complex tachycardia according to the regularity of the narrow complex tachycardia, either regular tachycardia, such as sinus tachycardia, atrial tachycardia, flutter, atrioventricular node entrant tachycardia, or atrioventricular entrant tachycardia, and we will cover those in more details in a minute. Or irregular tachycardia, the most important one is atrial fibrillation, but there are also other important differential diagnoses for irregular narrow complex tachycardia, such as atrial flutter or atrial tachycardia with variable block, multifocal atrial tachycardia, frequent premature atrial complexes, and less common causes of regular narrow complex tachycardia, which is the dual AV nodal non-reentrant tachycardia and AVNRT with intermittent block, and we won't cover those in this lecture. So how do we approach narrow complex tachycardia for diagnosis? In this lecture, we will discuss the algorithm published in 2016 European Heart Rhythm Association guidelines or consensus document on management of supraventricular tachycardia. And in this algorithm, the ERA suggested few steps to approach narrow complex tachycardia. These steps are first to check the regularity of the rhythm and to see whether it is regular or irregular. Second is to find the P wave and check if you can see a P wave. And if you can find the P wave, then determine the relationship between the P wave and QRS complex, whether the number of P waves is larger or smaller or equal to the QRS complex. And we will give examples in minutes. And finally, if it is P wave with one-to-one conduction to the ventricle, the so-called one-to-one AV tachycardia, we will determine the relationship between the P wave and the QRS complex, and further categorize this tachycardia into either short RP or long RP. So we'll go into these steps one by one. The first one is to determine whether the tachycardia is regular or not. And as you can see here, if it is irregular tachycardia, it's of course atrial fibrillation is the most important differential diagnosis of irregular narrow complex tachycardia, but there are also important and fundamentally different tachycardias than atrial fibrillation, and with subsequent different management. And to differentiate those, in atrial fibrillation, there is narrow complex irregular tachycardia with absent P wave. So you will see narrow complex irregular tachycardia, and you won't be able to find P wave before QRS complexes, and instead you may find these fine baseline undulations called F wave or fibrillatory waves. Now these baseline undulation or um, F waves could be fine as in this example, and could be coarse and as in this one, the so-called coarse AF. Still it is irregular narrow complex tachycardia. We can't find P wave before the QRS complexes, but there is coarse fibrillatory waves before that. Now another example of irregular narrow complex tachycardia is something like this. Still it is tachycardia, still it is irregular, but if you look carefully to the ECG, you can find well-formed atrial activity, well-formed P waves occurring at fixed interval. Now this, I cannot call this atrial fibrillation, okay? This is more likely atrial tachycardia or flutter with variable block, and it is this variable block that accounts for the irregularity of the rhythm. Because of this variable block, we can see this irregular rhythm. Another example for irregular narrow complex tachycardia is, again, this example. It is narrow, it is irregular, but when you look carefully, especially in lead 2 and lead V1, which are the leads when we can see P wave the best, you can again see well-formed atrial activity occurring at fixed interval. Thus, this is more likely atrial tachycardia or atrial flutter, and with variable block because the rhythm is irregular. Now, another example of irregular narrow complex tachycardia is something like this. Again, when you examine the P wave, you can find P wave before each QRS complex. Occasionally, these P waves occur with long PR, or they become non-conducted. So there is some atrial ectopies that conduct to the atrium, and some of them are not conducted to the atrium. This is why the rhythm is irregular. So this is basically a sinus rhythm, just with frequent premature atrial ectopies. Another example of irregular narrow complex tachycardia. This is probably the most tricky example of irregular narrow complex tachycardia, and you have to pay careful attention to the morphology of P wave in order to diagnose it. Again, for the first look, this looks atrial fibrillation. It is fast, it is irregular, but if you look specifically at V1 here, you will almost find that every QRS complex is preceded by an atrial activity, by a P wave. Now the P waves, they are not of the same morphology, but they or the same PR interval. You can clearly see that you have more than one P wave morphology, and each morphology has different PR interval. And this is what we call multifocal atrial tachycardia. It's not atrial fibrillation. It doesn't require the anticoagulation treatment we give to a patient with atrial fibrillation. This is why it is important to differentiate these tachycardia from atrial fibrillation. And again, the dual AVNRT entrant tachycardia and other forms are very uncommon. So these are examples of irregular narrow complex tachycardia, and the importance of these examples to highlight that not every irregular narrow complex tachycardia is atrial fibrillation. Again, atrial fibrillation is the most important differential diagnosis, but you have to pay careful attention to other differential diagnoses because treatment is fundamentally different for each of these diagnoses. Now, the second step is, if the tachycardia is regular, is to look for the P wave, and you have to inspect every beat and in every ECG channel to look for P waves. Now, if you can't find any P waves, there is a list of differential diagnoses. I won't go through all of them, but the most important one of them is the so-called typical AVNRT. So, what is typical AVNRT? AVNRT stands for atrioventricular nodal reentrant tachycardia. It is a tachycardia that arises from the AV node. The mechanism of tachycardia is that normally, in normal person, the atrial activity conducts from the SA node to the atrium and then passes in the AV node to the His-Purkinje system. And the pathway it goes through inside the AV node is called the fast pathway. This is the normal pathway that is present in every human being. Now, in some patients, there is another pathway inside the AV node that conducts electrical activity from the atrial and ventral, but at a much slower rate, and we call this pathway slow pathway. Now, under certain condition, what happens inside the AV node is that um, the impulse goes down the slow pathway slowly, and by the time it reaches this turning point, it propagates in two directions simultaneously. One of them down to the ventricle, and the other direction is up the fast pathway back to the atrium. So as a result, the atrium and ventricle activates in the same time. Again, this is an example of reentrant tachycardia, hence the name reentrant. Okay, we have two limbs, one limb for antegrade conduction down the slow pathway, and the other limb is for retrograde conduction from the ventricle to the atrium up the fast pathway. Okay, and this causes fast narrow complex tachycardia, and because the ventricle and atrium are activated at the same time, you cannot see the P waves. The P waves are buried and hidden inside the QRS complex. So if you look at each lead in this 12 lead ECG, you cannot find P wave, and do not mistake the T wave for P wave, because these are T waves, not P waves. Okay, and you cannot see any P wave. So the so-called typical AVNRT, one of the presentation is narrow-complex tachycardia with no visible P wave. Okay, and occasionally, as we will see later, you can sometimes see the P wave just just after the QRS complex, almost as a part of QRS complex, and we will show example for that later on. But for now, if you have a regular narrow complex tachycardia with no visible P wave, the most important differential diagnosis is typical AVNRT. Other differential diagnoses are atrial tachycardia with long AV conduction or focal junctional tachycardia, and we won't cover those. They are far less common than typical AVNRT. So if you can find P wave, you move on to step 3, which is determine the relationship between the P waves and QRS complex. And you have three possibilities here. The first possibility is that the atrial rate is greater than the ventricular rate. So we can see P waves, and when you count the P waves for each QRS complex, you will find that the number of P waves is greater than the number of QRS complex. And this is seen with atrial flutter, atrial tachycardia, and very less commonly the AVNRT. And this is an example of this form of tachycardia. This is narrow complex, regular, so step 1 is answered, and I can see P waves before QRS complex, so the second question is answered as well. Now, if you look carefully at V1, you will find that there are almost 2 P waves before each QRS complex, and these P waves occur at fixed interval. So this means that this is a tachycardia, a regular narrow complex with visible P wave and more P's than QRS complex. So differential diagnosis so far is atrial tachycardia or atrial flutter with fixed block. This is 2-to-1 atrial tachycardia or atrial flutter. Now it is possible to differentiate atrial tachycardia with atrial flutter with somehow Certainly. The way to differentiate atrial tachycardia from atrial flutter is by looking at two things. First, the rate of atrial or the rate of P waves. In atrial tachycardia, usually the PP interval or the rate of P waves is less than 24 milliseconds, where the atrial flutter the rate is much faster, above 240 beats per minute. And the second thing is to look at the isoelectric line between P waves in all ECG leads. If it is present, if there is isoelectric line seen between the P wave in all ECG lead, then it's probably atrial tachycardia. And if you cannot see isoelectric line so that the atrial activity is almost touching each other, then it's more likely atrial flutter. Now there are exceptions to these rules, and these are not 100% sure, and there are cases of atrial flutter that do not follow these rules, and vice versa. There are cases of atrial tachycardia that do not follow these rules. So they are not strict rules, but they can help you um, um, increase the probability of one diagnosis over the other. So back to this example, if you look at the P wave activity and you measure the PP interval, this is occurring at almost 200 beats per minute. And if you can see, there is almost always an isoelectric line between the P waves here. So we are talking here about atrial tachycardia. This is more likely, again, this is not 100% solid, it is more likely atrial tachycardia than atrial flutter. Now, moving on to the next possibility. So, if the P wave can be seen, we said that we will count the relationship between them, and if it is larger, it's either atrial flutter or atrial tachycardia. The P wave is more than QRS complex, and the other possibility is that it is narrow complex tachycardia, regular with ventricular rate greater than the atrial rate. Okay, and this is a subset of a very rare tachycardias, and I very rarely see them in my practice. Almost in over 15 years of electrophysiology practice, I haven't seen them except once or twice. So they are way outside the spectrum of this presentation, just mentioned here for your information, but very unlikely you will see this differential diagnosis. Just keep in mind that there is a possibility of narrow complex tachycardia with ventricular rate greater than the atrial rate, and the list of differential diagnoses includes high septal VT, focal junctional tachycardia, AVNRT, or nodoventricular, nodovesicular reentrant tachycardia. And again, I won't go into details in this group of arrhythmias. Now, the third possibility is that the P wave to QRS complex relation is neither more or less. And in this case, it is 1-to-1 tachycardia. So for every QRS complex, I can see a P wave. Now, we have to answer in this stage to move on to the fourth question is whether the relationship is short RP or long RP tachycardia. What does this mean? Now, if I can see one P wave for every QRS complex of the tachycardia, I determine the distance from the R to the P wave and compare it to the distance from the P wave to the subsequent R complex. Okay, so if the RP, which is the distance between R to the beginning of P waves, is shorter than PR, which is the distance from the P wave to the subsequent R, then we term it short RP tachycardia. But if it is longer, if the RP is longer than the PR, we term it long RP tachycardia. ببساطة شديدة لو البي ويف في النص الأولاني من الار ار انترفال، اوكي، في النص الاولاني من الار ار انترفال، يبقى بنسميها شورت ار بي تاكيكارديا. ولو البي ويف في النص الثاني من الار ار انترفال يبقى بنسميها لونج ار بي تاكيكارديا. واكوردنج للديفرنشال diagnosis دوت we have group of differential diagnosis of arrhythmias بتعمل كل المنظر. لو هي شورت ار بي تاكيكارديا بنبص على القياس بتاع الار بي انترفال اذا كان اقل من 70 ملي سكند او اكتر من 70 ملي سكند، وده هيرجعنا للليست اوف ديفرنشال دايجنوزز، نفس الليست لو ما قدرتش انت تشوف بي ويف. تقريبا كده لو انت مش شايف بي ويف خالص او شايف بي ويف immediately بعد الكيو ار اس كومبلكس لازقه في الكيو ار اس كومبلكس. the list of differential diagnosis is almost the same. again بنتكلم على التيبيكال AVNRT اول حاجه تاني اول differential diagnosis. so example of narrow complex regular narrow complex tachycardia with visible P wave RP less than 70 millisecond. Now in these cases it might be deceiving to find the P wave, and you may not believe that this is a P wave, but in this example actually there is a P wave at the end of QRS complex. So if you look at lead 2, again this is where we more likely to find P wave, and V1 you will find something at the end of QRS complex almost fused to the QRS complex, this very little as if it is S wave at the end of QRS complex. The same thing applies here. And in V1 there is another thing also. If you can look in here, there is terminal deflection at the end of QRS complex that actually is a P wave. And as you can see, because it is fused to the QRS complex, it is very short and the distance is almost less than 2 small squares, which means less than 80 millisecond or 70 millisecond. So if you don't believe that this is actually a P wave and it's not part of your S complex, one of the useful tip is to examine the sinus rate of this patient. Now, if this is part of the QRS complex, it should be there when the patient goes into sinus rhythm. But actually, this terminal part in the QRS complex is not present in sinus rhythm. It's not present in lead 2, and this small s at the end of QRS complex in lead 3, it's also not present in sinus rhythm, and this terminal R wave in V1 is not also present in sinus rhythm. So these small deflection at the end of QRS are not part of the QRS complex, and actually in this case they are hidden P wave at the end of QRS complex. This is how we can differentiate very short RP during tachycardia by examining the sinus rhythm. Again, the most common differential diagnosis for short RP tachycardia less than 70 millisecond is again the typical AVNRT, the one that we just talked about. Again, we said that usually it has a hidden P wave inside the QRS complex, but sometimes the P wave appear just after the QRS complex, mimicking what we call a pseudo S or pseudo R in pseudo S inferior leads or pseudo R in V1. So this is another way how AVNRT presents itself in surface ECG. Now, the next differential diagnosis, if you have short RP tachycardia, is short RP with RP more than 70 milliseconds. And the list of differential diagnoses includes orthodromic AVRT and other less common diagnoses, which are atypical AVNRT, atrial tachycardia, and non-paroxysmal junctional tachycardia. And we will focus on the most common one, which is the orthodromic AVRT. What do we mean by the orthodromic AVRT? An AVRT is a tachycardia mediated by an accessory pathway, which is an abnormal connection between atria and ventricle. Now, there are number of arrhythmias caused by accessory pathway. The one we are showing here is what we call an orthodromic AVRT. So it is an atrioventricular entrant tachycardia in which there is a re-entry between the atrium and the ventricle, and as we said before, the re-entry requires two limbs. In this form of tachycardia, one limb is the antegrade limb involving the AV node and his Purkinje system, and the retrograde limb that conducts activity from the atrium to the ventricle is the accessory pathway. So the orthodromic tachycardia is an is a tachycardia mediated by accessory pathway in which the antegrade activation, means the activation from atrial ventricle, occurs via the His-Purkinje system, and retrograde activation occurs via the accessory pathway in this pattern and in this re-entry pattern. And this on the surface ECG presents itself as narrow complex tachycardia, regular, with visible P wave, and the P waves appear after the QRS complex as short RP tachycardia with RP time longer than 70 millisecond, as you can see here. And the simplest trick to identify whether it is short less than 70 millisecond or short greater than 70 millisecond is if you can see any isoelectric line or any degree of separation between the QRS complex and the onset of P wave. And if you can see any separation between two, it's usually more than 70 milliseconds. Again, this is regular narrow complex, regular visible P wave with one-to-one relationship QRS complex with short RP and RP time more than 70 millisecond. The most common differential diagnosis for this form of tachycardia is orthodromic AVRT. Now, it is important when this tachycardia terminates to examine the sinus rhythm, because as we just said that orthodromic AVRT is mediated by accessory pathway, and usually during tachycardia there is no evidence of accessory pathway, or specifically, to be more specific, during orthodromic AVRT there is no evidence of accessory pathway. But when the patient returns to sinus rhythm, we can see an evidence of accessory pathway, what we call WPW. Okay, so what happens in sinus rhythm, that the sinus activity propagates in two directions. One direction is through the AV node and his Purkinje system, and the other direction is through the accessory pathway. And because the accessory pathway does not have the natural normal decremental conduction of the AV node, so it conducts fast to the ventricle, accounting for part of the ventricle to be activated before its time, before its normal time, hence the name pre-excitation. Okay, so in sinus rhythm we can see this evidence of pre-excitation as short PR and presence of delta wave. So as you can see here, we have delta wave, which represents the part of the ventricle activated by the accessory pathway, and very short PR representing the lack of decremental conduction down the accessory pathway. And this has very important therapeutic implication, as we will see shortly. Okay, so again, AVRT, orthodromic AVRT during tachycardia, narrow-complex regular, and it's important to examine the sinus rhythm to see if this patient has WPW as well, which he might or might not. Okay, so back again to our algorithm. To the fourth question is, after we determine it is regular and there is a P wave and the relationship between the P wave to QRS complex is 1-to-1, then we are now at the question of determining whether it is short or long. And if it is short, we cover the possibilities, whether it is RP less than 70 or more than 70 millisecond, and it's time now to cover the what if the tachycardia has a long RP. Now, the list of differential diagnoses in this tachycardia includes atrial tachycardia as the most common cause of long RP tachycardia, and other less common diagnoses that we will not cover is AVRT or atypical AVNRT, and I won't go in details. But it is important to know the atrial tachycardia. Now, in ICU, the most common narrow complex tachycardia ever in ICU is sinus tachycardia. Okay, and for many reasons, catecholamines, stress, pain, anemia, organ failure, there are many reasons that cause tachycardia, sinus tachycardia in ICU, and sometimes it's not uncommon to see them at very high rates. And it is important to differentiate sinus tachycardia as a form of long RP tachycardia from atrial tachycardia, which is also a long RP tachycardia. And the differentiation between the two lies in examining the morphology of the P wave. So it is important to examine the P wave and determine if this P wave is sinus P or not sinus P. Now, if it is sinus P, then you are probably dealing with sinus tachycardia, but if it is not, then you are dealing with other form of tachycardia. And what is the morphology of the P waves? Because the atrial activity in the normal sinus rhythm arises from the SE node at the high right atrium gain region, uh, the upper part of the posterior wall of the high right atrium at the cresta terminalis. The activation spreads from that point from right to left, from the right atrium to the left atrium, and from from craniocaudal direction, from upward downwards to the AV node. This causes the atrial activity to be of the sinus rhythm to be positive in lead 1 because it's activating from right to left, and positive in lead 2 because activated from craniocaudal, from upward downwards. Okay, and also causes the P wave to be negative in AVR because AVR records in opposite direction. So if you have a P wave activity that is positive in lead 1 and lead 2 and negative in AVR, then you are dealing with sinus P. And if it is sinus P, then the tachycardia you're facing is probably sinus tachycardia. And if it is sinus P, then you are probably dealing with other forms of atrial tachycardia. So to summarize the algorithm again, the algorithm relies on 4 steps. The first one of them is to determine whether the tachycardia is regular or not. The second step is to examine for the presence of P wave to see if there is a P wave or not. And if there is P wave, then you should examine the relationship between P wave and QRS. And you have 3 possibilities here: whether the P wave is larger than the QRS complexes, the number of P waves is larger than the QRS complexes, or the QRS complexes number is larger than the number of P wave, or it, if they have one-to-one relationship. And if they have one-to-one relationship, then you should examine whether it is short RP or long RP, and we have given examples for all of these tachycardia. Now, the next step is to manage what to do when you face narrow complex tachycardia in ICU. Again, the algorithm starts by looking at the regularity, whether it is narrow complex or wide complex. And again, there is a dedicated lecture for wide QRS complex tachycardia. And as I said before, there will be a differentiation between ventricular tachycardia and other causes of wide complex tachycardia. There are many algorithms for that. But in this lecture, we will cover only one important possibilities in narrow of supraventricular tachycardia presenting as wide complex tachycardia, which is actually irregular, not that very irregular, which is the pre-excited AF. We're covering it because it is very important, it is very dangerous to miss, and you should act accordingly, because once you see pre-excited AF or atrial flutter, you should immediately cardiovert the patient, and you should never use any beta blocker, calcium channel blocker, or any AV nodal blocking agent, because you might precipitate ventricular fibrillation if you do that. And this is an example of pre-excited AFib. It is wide complex tachycardia, irregular with variable QRS morphology, denoting variable degrees of pre-excitation. Once it is more like a spot diagnosis. Once you see this ECG, you shouldn't think much about it. This is a shout for cardioversion, if you see. So once you see this, usually the patient is at risk of hemodynamic instability or further deterioration, and you should cardiovert electrically. One important note that amiodarone is no longer accepted for cardioversion of pre-excited AF. If you want to cardivert, it's better by direct current cardioversion, or if you have ebutilide or other class 3 antiarrhythmic medications, you can use. Now class 1C antiarrhythmic medication you should use, if you are going to use it, the IV form, which is not readily available in Egypt. So be safe and electrically cardiovert this patient. Now for other tachycardias, the regular narrow complex tachycardia, We start by using vagal maneuver or adenosine. And even if the patient unstable, these maneuvers they do not take time, and the adenosine is very short acting. And even if you want the patient is hemodynamically unstable and you want to cardiovert him, you usually have time before the cardioversion arrive to perform one of the vagal maneuver if time allows. Now, what are the vagal maneuvers we are talking about? In ICU, we have a few vagal maneuvers. The most common one is carotid sinus massage, and we all know about it. It's important to highlight the contraindications of carotid sinus massage. Any patient with TIA stroke within 3 months, or ipsilateral stenosis or BRI. This is why it's important to auscultate by the bell of diaphragm over the carotid artery on the side you are performing the carotid sinus massage. And if the auscultation is not very accurate, and if you have Doppler, it's better to use it to see if you have any stenosis or not, or previous complication. And the idea about these complication is that you don't want to occlude a carotid artery that is stenosed already, because you might precipitate stroke or TIA by your maneuver. So it's very important to exclude any sign of carotid artery stenosis, BRI, or partial occlusion before performing the maneuver, and these are one ways of trying to avoid that. Previous complication from carotid sinus massage is obvious contraindication, and MI within 3 months, or history of ventricular arrhythmias because of the maybe potential profound response to carotid sinus massage causing hypotension or severe bradycardias complicating or predisposing to other complication. This is why we try to avoid carotid sinus massage in those patients. So if it is not contraindicated, the way we perform carotid sinus massage, usually we palpate for the carotid artery at the upper border of the thyroid cartilage. So we search for the thyroid cartilage first, and we slide to one side and press the carotid bulb is usually at the upper border of thyroid cartilage, and we press medial to the sternomastoid muscle and in a direction against the vertebral column, or specifically the spinous process of C6. And we do that by firm, gentle, firm but not very severe compression for like 5 to 10 seconds, and we monitor the ECG for the response. And it is possible that if you don't have a response on this side, is to try compress the other side, but it's important also not to perform simultaneous compression on both sides in the same time. Okay, so the other vagal maneuver we use in the ICU is Valsalva maneuver, or recently the modified Valsalva maneuver. And Valsalva maneuver is basically a forced expiration against closed blocks. هو بالبلدي يعني زي ما بتقول له يحزق. How we do it in the ICU, usually you ask the patient to blow in a syringe, 10 milliliter syringe. This is the Valsalva maneuver. And the modified Valsalva increases the response rate to Valsalva maneuver by doubling it. And the way it is done is you ask the patient to blow in a 10 milliliter syringe for like 15 seconds in semi-recumbent position, and after that you immediately raise the patient, you lower the head and raise the patient leg for another at least 15 seconds to potentiate the response to Valsalva maneuver. And this is how it is done. You just give a patient syringe, 10 milliliter, 10 cc syringe, and ask him to blow as hard as possible for the plunger to come back for at least 15 seconds, and at the end of that you lower the head and raise the leg for another 15 seconds. And this is the modified Valsalva maneuver, and it is far more effective than the Valsalva maneuver. It almost doubles the response rate, but obviously the patient needs to be hemodynamically stable and cooperative to perform this. Now the other rapid maneuver or the rapid intervention to terminate or diagnose supraventricular tachycardia is adenosine administration. Usually we give it at a dose of 60 milligrams, and if it doesn't work, we repeat it at 12 milligrams. But it is important to give it the right way. So adenosine has to be given in proximal large vein. So veins at the dorsum of the hand are not appropriate for adenosine administration. It has to be at least something in the antecubital vein, and it should be on a three-way by rapid IV bolus followed by rapid saline flush. And it is important to be given this way because adenosine has a very short half-life, and if you don't do this, probably it'll break inside the blood before it reaches the heart. It'll disintegrate inside the blood before it'll be metabolized inside the blood before reaching the heart. So to avoid that, you have to give it by rapid IV bolus followed by rapid saline flush in order for it to work. Now, it is important to have a crash cart or resuscitation equipment available before giving adenosine. And the reason for that adenosine may precipitate AF. And in cases of SVT or AVRT, it may precipitate pre-excited AF, which may degenerate into ventricular fibrillation. It also may cause rebound one-to-one conduction after transient AV block in cases of flutter or atrial tachycardia with 2-to-1 conduction. So precautionary word of advice is you have to have a crash cart or resuscitation equipment ready before giving adenosine in case the patient deteriorates into a more serious forms of tachycardia. Now, what happens when you perform vagal maneuvers or you give adenosine? Now, you have potentially four responses. The first response is termination. You can perform vagal maneuvers or adenosine, and you can see as this the tachycardia terminates suddenly and the patient goes back into sinus rhythm. And this is usually consistent with AVNRT or AVRT most of the time. Now, there are very rare causes for adenosine to terminate sinus node entrant tachycardia or disincentive atrial tachycardia, but these are the exceptions. And sudden termination is usually consistent with reentrant tachycardia, such as AVNRT or AVRT, the one we discussed before. Now, the second possible response is to have a transient or temporary AV block of AV node with persistence of tachycardia. So as here you have narrow complex, regular narrow complex tachycardia. Possibly you have a P wave before the QRS complex here. But when you give adenosine or when you perform vagal maneuver, you see that there is block in AV node. You don't have QRS complexes anymore, but the tachycardia in the atrium continues at the same rate until the effect wears off and you have now recurrence of ventricular conduction. Now uh, this response is consistent with either atrial flutter or atrial tachycardia because we know now that the AV node is not essential for the maintenance of this tachycardia. So this tachycardia, despite the block in AV node, the tachycardia did not terminate, so it has to be tachycardia originating above the AV node, meaning the atrium or atrial flutter or atrial tachycardia. Now, the third response is transient decrease of heart rate followed by acceleration of heart rate. So we don't have termination, we don't have block in AV node. All what we get is just transient decrease of heart rate followed by acceleration again. And this is seen with mostly sinus tachycardia or other forms of automatic atrial tachycardia. Now, the final response is no response at all. And usually this means that either the vagal maneuver you're doing is not effective, or the adenosine dose you're giving is not enough, or you're not giving it in the right way. You're giving it by slow injection, or you're not giving enough dose of adenosine. So these are the potential four responses to vagal maneuvers or adenosine. So what happens if you don't have response to vagal maneuver of adenosine? Now, if the tachycardia continues, but the patient is hemodynamically unstable, obviously you will need to perform synchronized cardioversion. Now, hemodynamic instability does not only mean low blood pressure. It could be in the form of persistent chest pain or pulmonary congestion or heart failure. So there are other forms of hemodynamic instability other than just low blood pressure. So if the patient is hemodynamically unstable in any way, then you perform synchronized cardioversion. But if the tachycardia continues and the patient is hemodynamically stable, you are free to control the rate or try other medications like beta blockers, diltiazem, or verapamil. Now, after termination of tachycardia or after control of the rate, your next intention is to prevent the recurrence of this tachycardia. And in ICU, it's more commonly triggered or precipitated by something that occurs in the ICU, whether electrolyte disturbance, drugs. Most of the patients are using um, adrenaline, catecholamines, noradrenaline, beta 2 agonists, bronchodilators, aminophylline for this condition. Causes like hyperthyroidism, pulmonary embolism, pericarditis, myocarditis, all these causes must be searched for. We must actively search for these causes and correct them if possible to prevent recurrence of these tachycardia. And this is true for all forms of tachycardia, whether it is reentrant tachycardia or triggered activity or abnormal troponicity. You have to search for underlying causes and correct if you don't want this tachycardia to recur shortly. Now, there are other specific treatment depending on the type of tachycardia, and we will discuss them briefly in this section. Now, if it is irregular narrow complex tachycardia and we diagnose it as AF, I won't go into details for the AF because we have separate lecture for AF to manage anticoagulation rate versus rhythm control and upstream and control of risk factors. So I won't go into details. And if it is the other form of irregular neurocomplex tachycardia, atrial flutter or atrial tachycardia with variable block, we deal with it as if it is atrial flutter or atrial tachycardia. And finally, if it is multifocal atrial tachycardia, we correct the underlying cause. It is very important. Again, usually you will have something in this list that needs correction. If you can correct it, well and good. If you can't correct it right away, then metoprolol is very effective if the patient doesn't have any pulmonary disease. And if the patient has pulmonary disease, then you use other calcium channel blocker, specifically the non-dihydropyridine, verapamil, or diltiazem if the patient has pulmonary disease. Now, if the patient has regular narrow complex tachycardia and we diagnose it at AVNRT or AVRT without WPW, the subsequent treatment is virtually the same. Catheter ablation of this arrhythmia is very effective and it is very safe and saves the patient the need for lifelong treatment, and it would be better if the patient can have it. Other alternatives is calcium channel blocker, again the non-dihydropyridine, diltiazem or verapamil, or beta blockers. They are equally effective in this condition. Now, if it is AVRT with WPW, again, this is why it is important to examine the sinus rhythm after termination of tachycardia. Now, catheter ablation is far more important here. It is far better option. But if it is not available, not possible, or the patient doesn't want it, then you cannot use any AV nodal blocking agent. Beta blocker, calcium channel blocker, adenosine, or lanoxin are contraindicated in this condition. So the only treatment that you can give for prevention of future recurrence is propafenone and flecainide. Now, it is important to realize that if you are giving propafenone or flecainide for patient with history of AF or atrial flutter, it is important to combine it with AV nodal blocking agents such as beta blocker or calcium channel blocker. And you should not give propafenone or flecainide alone in patient with history of pre-excited AF or pre-excited atrial flutter or tachycardia. You should combine propafenone, flecainide with beta blockers or calcium channel blocker. And again, you have to pay attention that propafenone or flecainide are contraindicated in patients with structural heart disease or ischemia. And in this case, ablation again is a better option. And if ablation is not available or not desired by the patient, then in very small sprint here, amiodarone is the last option. And try to avoid using amiodarone for long-term arrhythmia treatment because of its side effects. Okay. Now the last, not the last actually, the last in this list here is atrial tachycardia. Again, ablation is effective if the tachycardia is incessant, is persistent, because it helps mapping and accurate and successful termination of the tachycardia. Again, if ablation is not possible or not desired, you can use calcium channel blocker, beta blocker for control of the rate, or propafenone or flecainide if they are not contraindicated. And again, amiodarone is the last option. Now, if it is atrial flutter, it's important that after cardioversion of atrial flutter, patient needs to be anticoagulated for at least 4 weeks. And after those 4 weeks, the decision for anticoagulation relies on the Chadvas score as an AF, and again, this will be covered in more details in AF lecture. Ablation is very effective if the flutter is recurrent or poorly related or causing the patient tachycardiomyopathy. In this case, ablation is almost curative. And it is important to note that restoration of sinus rhythm by medical treatment in cases of atrial flutter is very difficult. And more than often, your best hope is just to control rate, to accept the flutter and to control rate if you desire only to use medical treatment. So if you want to control the rate, you can use beta blocker, calcium channel blocker, dihydropyridine. And again, propafenone or flecainide can be used only with AV nodal blocking agent and only if they are not contraindicated. Final word is a word on artifacts, and it is not something that you will not see. Actually, you will see it more than often. And this is an example of patient having tremor artifact. He's just shivering. For the first look, you might think that these are fibrillatory wave, coarse AF, in this here. But if you examine lead 2 specifically, you can find well-formed atrial activity. And actually, this is sinus. This is just sinus rhythm. So how we differentiate artifact from other arrhythmias? Usually, artifact is not present in all lead. And if you can find one lead with well-formed atrial activity, then this is not atrial fibrillation. What you're dealing with is probably artifact. And you can see that most of the time you don't have fixed morphology, although strange enough you can see that. And occasionally you can see atrial rate that are non-physiologically high, that beyond the possibility of the atrium to fire. Now these are real life examples. These are examples from my practice, and I took them for this lecture. And again, this is narrow complex. It's not tachycardia. It's hardly tachycardia. But if you look here at lead 2 or lead 3, you might think that there is some sort of atrial arrhythmia going on with fixed block, maybe 2-1 or 3-1. But if you look carefully on lead V1 or other chest leads, you can see a well-formed atrial activity seen before before every QRS complex. So this is clearly an artifact, and this patient is just sinus rhythm with artifact. Another example, another deceiving example, and actually this one was diagnosed as atrial flutter by one of our colleagues. And you can see clearly the so-called or deceiving sawtooth appearance in inferior leads and in lead 1 here. But again, if you carefully inspect lead 2, you can see well-formed atrial activity. And this is simultaneous recording of all leads. So there is no way you have an arrhythmia in one lead and no arrhythmia on the other lead. So this must be artifact, and it was artifact. This patient doesn't have any arrhythmia. So my take-home message is that not every irregular narrow-complex tachycardia is atrial fibrillation. As I showed you before, there are a list of differential diagnoses for irregular narrow-complex tachycardia. AF remains the most important, the most common, but there are other causes for irregular narrow-complex tachycardia with fundamentally different treatment strategies you should be aware of and you should differentiate. And for regular narrow-complex tachycardia, the key is in the P. As we said before, the second, third, and fourth question relies on identifying the P, finding the relationship of the P to QRS complex, and whether it is short or long RP tachycardia. And don't forget about vagal maneuvers and adenosine. It's very easy. If they are done correctly, you can have very important information from them. And finally, don't fall for artifacts. Thank you very much.